we're going to cover how to set an I time without an I time order. And there's 3 steps to doing this. It's very important that you set the I time right off the bat when you first set up the vent, and we'll talk about why later. But here's the steps you go to. When you first start, you're going to start with the ordered FiO2, PEEP, peak airway pressure, and rate. And you're going to start that, and you're going to guess at the I time initially to just whatever you think is appropriate for the situation, but you're going to change it based on the waveforms alone, not based on the patient's size, but the waveforms alone. So you can see right here, should we put this on a patient, you can see our flow on our float curve doesn't get to 0. It's still decelerating when the I time has terminated and you're forcing the patient to exhale at that time. If you look at the peak pressure that you're ordered at, it's at 25. It's hitting 25. And when you look at the volume, you're getting 315 out on expiration. So the appropriate way to do this is first, we're going to set the I time minimally so that our flow curve will at least get to the 0 baseline before it exhales. And you're going to always get that to get to 0. If for some reason, for the situation, you cannot achieve the 0 flow on your I time, and this may happen on various situations, then you need to have an order to tell you what to set the I time at, because without setting it by the flow, you have no basis of picking an I time. So on this kid, we would put this on and we would see that our I time is too short because the flow is still going into the vent or into the patient's lungs here, and the lung is still expanding because there's still flow moving towards it, and then you exhale. So what we're going to do is we're going to give the I time a long enough time, or the pressure to be held long enough for the lung to totally inflate so that the flow goes all the way to 0. So at 1.1 seconds, you can see the flow is almost at 0, but still not quite. So I would still go a little bit further. Maybe you go to 1.2 seconds. And I'm going to look at my waveforms. Okay, and let's say right there we get all the way to 0. You still got a smidge more, but that's really close enough to call good. Okay, so now we're at 0. So next, we're good with 0 on this patient. The next thing we're going to look at is the patient on the ordered rate that you just set up, is the patient exhaling all the way to baseline before the next breath has been initiated? If it isn't, that would be auto PEEP, and that's not what we want to happen unless the physician is aware of it. So after setting our 0 flow I time, we're going to look next and see, am I coming all the way out before the next breath? And if I am, like I am here, I got plenty of 0 flow happening between breaths. I can leave the I time there and move on about my business. If I'm not, for whatever reason, let's say they wanted to start the kid's rate up at, let's say, 35 times. So we still went through our progression on the rate of 35, and we got our flow to 0 on the I time, but with the rate of 35 they ordered, I don't exhale all the way. I'm trapping flow. So that's going to trap PEEP, and that means the patient's going to be on a higher PEEP than what the doctor ordered and needs to be aware of that situation. So in this situation, because we have an ordered rate of 35, we have to have the physician tell us what I time does he want. Either he needs to come down on the rate so we can get to 0 flow on the I time. If he's not comfortable with that, then we need to have him tell us what I time do we have to set so that that trap doesn't happen, or he's good with that trap happening, but he still needs to order the I time. So in this situation, I would have to shorten my I time so that exhalation fully happens. You can see here at 0.5 seconds, now I have time to exhale all the way. However, this is rarely is this a good process to happen, because what you're doing is you're just ventilating the very half portion of the lung that's really compliant here. And your rate is so high that because you're trying to ventilate just the upper part of the lobe, or the most compliant part of the lobe. So it's usually, clinically I found, better to first start with the 0 flow, minimally, if you're first initiating a vent, and then move my rate down to allow them to exhale with that I time, and evaluate your end tidal and your blood gas to see if that's not going to work for you. But 9 times out of 10, it typically is a better way to ventilate than to just shorten your I time so that you can exhale all the way because of the rate that's set. The third factor is a hold. An inspiratory hold can be achieved by setting your I time longer than what is physiologically necessary to expand the lung at the ordered pressure. This is seen by a flat spot on your flow curve. It's telling you basically at the 1.2 seconds that I had set prior, the lung is fully expanded at that 1.2 seconds everywhere to the pressure that's ordered, yet your I time is longer than that time frame takes to happen, so that I'm just going to hold the pressure. I'm not going to increase any volume to the lung. It's not going to increase your minute volume. All it's going to do is hold that pressure longer in the lung, and this should help recruit lung tissue. So this is also a technique we can use if needed within our I time settings, as long as it's within the criteria that we have set up for patient size without an order. What we have to do if we decide to give a patient an I time hold for whatever reason, being they have atelectasis or they're hypoxic on 100% and need more mean airway pressure, is we have to make sure that they're not fighting the I time. So fighting the vent, everybody knows what that means, but what it means is the patient is trying to exhale. Once this flow gets to zero, every patient that's not sedated or paralyzed is going to attempt to exhale. So if this patient on the vent that you're trying to give an inspiratory hold to with an elongated I time is not sedated to the point that they don't have a respiratory drive, they're going to try to exhale. And when they do, your pressure curve is going to look like this when they try to exhale. Once we get to the flat spot, they're going to try to push out. And that's going to drive the pressure on your PIP, your manometer readout of the vent. It's going to drive it higher than what you have set, for one, because they're adding a resistance to the pressure, and you see it spikes up to 28 when the patient tries to exhale against the I time. Now this we do not want either, because what this is going to do is cause agitation and increase caloric intake, and the patient is not going to be comfortable. So we don't want this to happen. So if the situation calls for setting a long I time on someone, you want to recruit their lung with an elongated I time, as long as they're not producing this waveform here where they spike up the end of it. As long as it's nice and flat with the elongated I time, then it's okay. If it's flat, they're not trying to exhale, whether they don't want to exhale, they're too tired, or they're sedated and paralyzed, or just heavily sedated, it's not an issue. You can recruit and the patient is fine. However, if they fight it, it's a non-issue. You have to pull the I time back to at least zero flow to stop the fight. And at that point, you can leave it at the zero flow because they shouldn't be fighting it. If they are fighting it at the zero flow, then you need an order for the I time to be set. Any deviation off of these waveforms, we need to have the physician aware of the situation so they can make a clinical judgment call on the amount of I time